Everyone will go and get started on chapter 11 over airway emergencies. This is part one, probably going to be two, maybe three parts. So something y'all aren't going to be aware of because you'd be watching these videos in sequential order is I a couple days ago recorded chapter 17 for Laura Chapin, and that cover there's tremendous overlap between the respiratory chapter, which is chapter 17, and this chapter. So if you struggle with this video, I recommend you also watch chapter 17, part 1. That covers like anatomy, physiology, airway stuff that I'm about to cover again here. So I'll recapitulate that. If you struggle with this, which you might, this is very important, I would recommend that you watch chapter 17, section 1 on the YouTube channel. So let's go ahead and get started. So this is airway management, right? Um, and I start that video by saying that EMTs make a big difference in respiratory emergencies and especially in airway management, right? Because without an airway, you most certainly will die. Like it's inevitable. You will die without an airway. You have about 5-10 minutes before you're just completely dead. If you do not have a patent airway. So the cool thing is EMTs and paramedics and physicians and nurses, but especially EMTs and paramedics, like this is our bread and butter. Like airways are where we save a lot of lives and we make a really big difference and we're really good at it and we're trained on this really heavily. And with that, since it's a big part of what we do, we're tested on it heavily. So very important information. They love to ask anatomy physiology questions as it relates to airway because they want, of all the systems they want you to have a good understanding of as far as anatomy physiology, some of the nitty gritty details, it's airway. At the EMT level even, they still could bang you up on some of the nitty gritty anatomy physiology details because it's high yield and we need to be able to identify structures and know how they work and that's important as it relates to pathology and treatment of pre-hospital patients. So basically, the algorithm for you have to know this. Get a tattoo of it. You have to know the algorithm to solving these types of problems will always be your safety first. Okay, so we don't go stepping over power lines. We don't go into dangerous scenes until we're cleared. Right? We don't pull people from burning houses. Right? So safety first. Okay. Anytime your safety is threatened, you have the right to retreat. Right? It's not abandonment. So safety first is always going to, if there's a question on there that relates to your safety and you putting your safety or your partner's safety first, that's the correct answer. And then after that will be circulation. Okay. So if someone's not breathing or they don't have a pulse, we start CPR. And then right after that's airway breathing. Okay. So why am I telling you this? What they'll do on these exams is they'll give you a scenario, a clinical vignette. A vignette's a story, right? Of a patient and they might say, well, they have gurgling sounds in their respirations and their front 5 teeth are knocked out, but you feel a carotid pulse. However, the attacker's standing over you with clenched fists and breathing heavily. What should you do, right? And the answer is you should retreat to safety, okay? Because they're telling you you're unsafe. The attacker of this patient is standing over you. You need to leave. You're not safe. But we could do the same scenario, right? Patient unconscious, laying supine, which is on your back. Has his front 5 teeth knocked out, bleeding heavily from the mouth, gurgling sounds in the airway, has a carotid pulse around 80 times a minute. What should you do first, right? You assume the scene is safe. Uh, since he has a carotid pulse, we're gonna have to fix his airway. Okay, so we're probably gonna need to suction or use a bag valve mask or something to that effect to go and start treating this patient. So you're gonna see a lot of this, and it really frustrates students because they'll be like, but you said, but I'm telling you, the answer will always be your and your partner's safety first, and then circulation. Okay, so if they don't have a pulse or if they're bleeding out, we fix that. We start CPR, we put on a tourniquet, or we stop the bleeding, and then their airway. We have to make sure air is going in and out. Okay, so the mouth and trachea need to be clear, nose need to be clear, and then we'll fix their breathing with a bag valve mask or something to that effect. So if you can really understand that algorithm, I kid you not, that's probably a third or more of your final exam in the national industry, okay? That algorithm is very important to know. So safety, circulation, airway breathing, in that order. That's how we assess, that's the life threats, because what they'll do on these exams is they'll say, what's the most appropriate next action, right? Or what would you address first, right? And those are really difficult questions, but they're not too difficult if we know the algorithm and we know, okay, we do this and then we do that and then we do that. That's the order. So enough of that. I'm kind of going off on that and I'll stop. But let's talk about airway, right? So basically, we need to make sure that patients have what's called a patent airway. That's that word right there. It's called patent, not patent, patent. okay, airway, and assure your patient's breathing adequately, but really in that order. You have to make sure they have an airway, and then we start worrying about, are they breathing adequately, okay? Just because someone's breathing 2 times a minute, they're breathing, right? But that's not adequate respiration. That's not adequate. So there's ways they'll trick you on that, and I'll talk about that more in a bit. But as we know, oxygen reaches body tissues and cells through breathing and circulation. So we breathe air in, we breathe oxygen in, we breathe carbon dioxide out. There's this exchange through simple diffusion in the lungs, at the alveoli, at the capillary membranes. It picks those two up and drops the one off. And then it goes through the circulatory system down to your big toe and up to your head, drops it off, drops off oxygen, picks up CO2, and then carries it back to the lung, and the cycle never stops until we die. But there's pathology all along those ways, and we'll talk about where the pathology is. So something that I find interesting about medicine is, look, guys, drop my pen. There's pathology here, and 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 here, right? There's pathology everywhere. And there's conditions for each place that there's a pathology. And so we have to learn where things go wrong and what the pathology is and how we fix it. And, all that. That's medicine, right? That's what we do. So just realize that as a generality that I think is kind of interesting is, like, at any point of this cycle, something can go wrong, and it will go wrong in humans. And we have to know what that's called and how to fix it. So that's medicine in a nutshell, right? So now, the airways divide into the upper and lower airways, and I talk about this in chapter 17. I'm going to quit saying that because it's the first time you're hearing this. But the upper airway is going to be at the level of the vocal cords up, okay? That's the demarcation zone, right? The level of the vocal cords, okay, also known as the larynx, and up, so the mouth, the nose, the epiglottis, all that. That's upper airway, okay? And then from the level of the larynx or the vocal cords down, the larynx, vocal cords, same thing, down, right? That's lower airway, okay? And we're going to talk about where that sits, but just realize that, okay? And ventilation is the exchange of air between the lungs and the environment, okay? So we don't really call it, this is not a respirator, right? This is a ventilator, right? This is a bag valve mask, but we ventilate patients with this device. We don't respirate them. Now, respiration is the process that occurs through this mechanism, but this is a ventilator, and you've heard, and this is a layman's term, right? When someone's attached to a breathing machine, right, with an endotracheal tube, we don't call that a respirator. We call them ventilators. They're on the vent. Okay, so that where ventilation is it's like a physical process of moving air in and out of the lungs, in the lungs into the environment, back and forth. Okay, sometimes that fails, and we'll do it with a bag valve mask, or we'll do it with an actual mechanical ventilator, or something to that effect. Okay, so let's talk about some just good old anatomy and physiology. So this will just be a review. Everything on here is fair game. So what I'm probably going to do at some point is out in class or on a quiz or exam or something to that effect, a Canvas assignment, you're just going to have to label these things because they're that important to know. And this is a very, very elementary level. I would say elementary. This is a very basic level of the anatomy. So we do need to know what each of these structures are blindly. Right? You need to know this is the carina, right? You need to know this is the apex, this is the base, right? So you need to know bronchioles versus the bronchus, right? So we need to know these things. So anticipate that to come to where I'm going to ask you to just label something similar to this, okay? It'll probably be in class. I'm just going to throw you a piece of paper and say, hey, label this. So let's just start at the beginning, okay? So we know that air comes in through the nose traditionally, right? And normal respiration, we breathe in and out of our nose, right? We can breathe out of our mouth, but typically it comes in and out of our nose, okay? And the idea is it comes through the nares, right? The nares are the holes within your nose, and then it comes back into the nasal pharynx. And let's talk about what the job of this area is. It is to warm and humidify and filter air, okay? So there's a lot of blood vessels that run through this area. They're called nasal turbinates. And what nasal turbinates do is they turbinate, they create turbulence of air. So they move air around through this really rich blood area, and blood's hot. It's body temperature, 98.6 degrees or Fahrenheit. So what happens is we're heating air because there's a lot of blood back there. So cold air comes in, it meets the hot blood in your nares, or in your nasal pharynx, excuse me, and it gets warmed, okay? The thing that happens before that, I kind of jumped ahead, is it gets filtered. So the hairs in your nose and the mucus in your nose, it filters out particles, okay? That's by design. And that's where you get your boogies and all that stuff, is it's filtered air, okay? And really boogers are dried up mucus. But, so we filter it, we create turbulence and we heat it. We also humidify it. Mucus will humidify this air. Okay, and then it goes this area right here. It's very important. It's called the nasopharynx. Okay, that's this word right here. That's how it's spelled. Recognize that nasopharynx. Okay, and then it goes back to this back in your oral cavity called the oropharynx. That's this word right here, oropharynx. Okay, and the area between these two is called the pharynx. Okay, so you do need to know the distinction between these. It's very obvious, right? Nasopharynx, oropharynx, and then the pharynx. Okay, obviously, you know what the mouth is, you know what the teeth are, you know what the tongue is. Okay, we're going to talk about these more here in a close-up picture on a coming up slide. But basically, it'll move through these passages, gets filtered, warmed, humidified. That's the idea. Okay, and then there's this level right here at the epiglottis. The epiglottis, I'm going to show you a close-up picture in a minute, but if this is your trachea, right, this is the hard tube in the front of your throat, there's a flap that sits over it. And what this flap does is when we swallow, like water or spit, food, whatever, this flap called the epiglottis, and it's pretty rigid, it's a piece of cartilage, will go down like this, and it covers the trachea. So this is what keeps you from choking when you swallow. And then when you're done swallowing, it goes back up, and now air can come back through. So when we swallow, the epiglottis will close over the trachea, your food goes down, and then it opens back up, and air can go through the trachea. So that's how that works. And then the larynx. Remember, the larynx is the other word for the vocal cords, more or less. We'll keep it at that. And so this is where, obviously voice, the biggest portion of voice and noise is made through the larynx. Below that is the trachea. So let me point something out. Here up, and they did this. It's the upper airway, okay? That's the level of distinction, okay? The larynx up is the upper airway. So how am I going to test you on this? I'm going to say, what level is the epiglottis? Is that the upper airway or lower airway? And you need to know that is the upper airway. It is in this box that I just told you about, right? So it's the upper airways, okay? And then from the level of the larynx down, that is the lower airways. So I could say, what is the carina and what is it, the upper airway or lower airways, right? That's the lower airways. We're going to talk about that, okay? But that is commonly tested. It's a really quick and easy anatomy question. Easy points if you understand that, okay? So we have our airway, okay, this tube, right? So it's a rigid tube because it's got cartilaginous rings that go around it called the trachea. So the trachea should not collapse on itself in adults, right? So it is like a rigid tube, okay? And you can feel this. It sits in the front of your throat. And so if you were to push right here, you can feel that. Don't push crazy hard, but below your thyroid and cricothyroid cartilage is the trachea, okay? And so the trachea is a tube. It's probably around that big, probably like that big around in an adult, and it allows air to go down. And so it should not collapse on itself. And I want to point something out. Directly behind the trachea, like they sit right on top of each other. Trachea is up front. Directly behind that is the esophagus. The esophagus is the food tube. So this is where food goes from your mouth down into the stomach, okay? But the trachea goes down and it bifurcates. What is bifurcation? It's when it splits off into two. Bi means two, okay? Like a bicycle. And so it bifurcates. But we have a special name for this area of bifurcation. It's my dog's name. She's an angel. It's called the carina, although my dog's name is Karina, but it's spelled the same. It's called the carina. So this is called carina, and this is where the trachea bifurcates, okay? And so it goes to the left and the right. And something I want to point out that this model doesn't do a good job showing is how this actually looks. In a real person, if this is your trachea, and this is the patient's right side, so that's the patient's right side, and this is the patient's left, it kind of looks like that, okay? So this level right here is the carina, that's where it bifurcates. But what happens is the right side is not as acute of an angle, okay? The left side just juts off really, really hard. Why is that? The heart's here, right? The heart's sitting right here. So it kind of juts off really hard. And so the reason I'm telling you this, if someone's standing up straight and they choke on food or they choke on some lemonade or whatever, it's probably going to go into their right lower lobe if they're standing up, which is going to be most scenarios. So that's worth knowing. Why is that? Because think about it. if you're a piece of food or water, you're going to follow the path of least resistance. It's a lot easier to go this way than it is to go here and take a sharp turn to the left. It just doesn't happen unless the patient's laying on their left side. So that's just rare. So typically we should know that when people choke on food or water, it typically, not always, especially if they're standing upright, will go, or sitting upright, will usually go in their right lung, okay? And because of gravity, it'll go to the right lower lobe, okay? Now, okay, moving forward. We have obviously two lungs, okay? If you didn't know that, I'm concerned. And so one thing I want you to know, this is the patient's right, okay? This is the patient's left, okay? So one thing I want you to know is that the right lung actually has three lobes. Okay, so you need to know the right lung has three lobes, and it might be intuitive that the left lung has two lobes. Why is that? Because the heart really does sit in the center of the chest for the most part, but so the heart is center, but a good chunk of it goes to the left. Okay, so the heart sits over here. So I like to think the heart sits like this. I'll just draw it for you, right? So the heart really does sit like this more so. That's what it looks like on an X-ray. So the ventricles sit a little bit in the left side of the chest. And so the way I kind of rationalize, like, why does the left only have two lobes, is because I rationalize, well, the left side of the chest had to make room for the ventricles, right, the bottom part of the heart, so which is a big chunk of muscle of the pump. So basically, that's something to know. So you need to know the right side of the lung has three lobes, the left side of the lung has two lobes. Okay, um, and well, I won't get into that. So moving forward, we go from the trachea to what's called the main bronchus, okay? And they're pointing that out here. So this is the left main bronchus, and this is the right main bronchus right here, okay? And so from there, we go into bronchioles, okay? So bronchus, right? Then bronchioles, and then it gets a little smaller, which we don't need to know, and then it juts off into the alveoli. What are the alveoli? That's these things. And these alveoli are little grape-like clusters that sit in our lungs. There's millions upon millions of these in our lungs. And they really do look like this, but something I want students to know is these are microscopic, okay? So you would not see this with the naked eye. You would need a microscope to see this, but they're microscopic. And so what happens is the alveoli are lined with these capillary membranes, okay? And what are capillaries? This is the junction of the arteries and the veins at the smallest level. So we're talking like, we're going from like major highways to side roads to dirt roads, right? So they're getting very small, very narrow roads where they join together. And basically, you can see capillaries on our skin right now as we speak. Again, really these are microscopic, but we can demonstrate what capillaries are by just pushing on our finger, okay? So if I were to push on my thumbnail or on my fingernail, right, we talked about this in patient assessment, and push down and let go, right, that's testing capillary refill. So what I'm doing is I'm pushing blood out of those capillaries, and when I let go, since I have good perfusion, it goes right back into the capillary beds. So there is these capillary beds that are surrounding these grape-like clusters within the lungs called the alveoli. This is the functional unit of the lung where gas exchange takes place. Let's recapitulate this, right? What's gas exchange? Gas exchange is where we have, let's just start with my brain, okay? So my brain's working really hard just talking and working my way through this lecture. So it needs a lot of oxygen, needs a lot of glucose, right, to do its job. What's bringing it to the brain? Blood. Arterial blood is bringing glucose and oxygen to my brain. And so as I'm working through this, I'm using energy, right? I'm going through cellular respiration, electron transport chain is taking place. And then so I'm using up oxygen, and in exchange, CO2 is being created by the electron transport chain and cellular respiration, okay? So oxygen is being dropped off to my brain, CO2 is being created, and now CO2 is building up and it's going to be carried away in the venous blood. The venous blood is going to carry this through, in this case, the superior vena cava, right? Well, the carotids in the superior vena cava, into the right atrium, and then through the tricuspid valve, through the right ventricle, into the pulmonary artery, and then into eventually these capillary beds, where deoxygenated blood that is low in oxygen and high in CO2 will go to these capillary beds within the alveoli. They're going to drop off CO2 and they're going to pick up oxygen. So the blood will literally turn from a bluish purplish color to a red color. That really does happen. You've seen this when they draw your blood. It's purple in color because we draw venous blood almost always. And if you've ever bled and it got on paper or something exposed to oxygen in the environment, it turns red. So that is not just your book. That is real life. It really is purple and red in color, depending if it's venous or arterial blood. So anyways, That's the pathway, okay? So we do need to know that. I talk about this in the respiratory chapter, and I tell you that you need to be able to explain that to me. How does a cell create, do its job, right? We just use the brain or the calf muscle or my big toe or whatever. How does it do its job? What does it need to do its job, right? Glucose, oxygen, right? To create ATP. ATP is used, right? But then we create CO2. CO2 is picked up in the venous blood. It's carried to the heart, then to the lungs, then to the alveoli. Gas exchange takes place through simple diffusion, and then it's picked up in the pulmonic vein, goes to the left side of the heart, out through the arteries, and then the process keeps going until we die. Okay, so that's the process that we need to know, and you should be able to thoroughly explain that to an 8th grader or 9th grader, right? You should be able to explain this to someone in the words that I just used. So don't perhaps just use the exact words I used, but be able to explain that to someone. Like if you can explain something, you really do understand it. And I use the example of explaining it to a 10th grader because if you can explain it to someone that doesn't know anything about medicine, then you know it, right? Then you know the material. Okay. So again, the major function of the upper airway is to warm, filter, and humidify air brought into the body. That sounds like a test question. The pharynx is composed of the nasopharynx, the oropharynx, and the laryngopharynx. Laryngopharynx is, again, the larynx, right? That's like where our vocal cords are at. They call that specific little area the laryngopharynx, okay? It's not a structure, it's an area. It's not a structure per se. Now, this is a little bit more detailed of the upper airway, but I do need to point out some structures, okay? So we'll just start over here. This is the mouth, obviously. The tongue, it's a very large muscle, okay? And it has sensory and all those other issues, okay? Now, under that, you have this little thing that connects your tongue to the bottom of your mouth. That's called the lingual frenulum, okay? And then the gingiva is obviously the gums, right? Gingivitis. And then the teeth, okay? Now, moving back, you've probably seen that little, as the rappers say, dangly, dangly thing in the back of your throat. That's called the uvula, okay? And what the uvula is it's what it looks like. It's this. It sits back there, and it has a big role in helping you swallow. One, and then two, it helps with your gag reflex. Okay, so when something touches this, it stimulates cranial nerve number 9, right, and then it tells cranial nerve number 10, the biggest nerve, like, oh hey, something's back there. This could create an airway issue. You should gag, right? So that's the function of the uvula. Now, something to point out: the uvula should free hang. It shouldn't point one side to another. So it should just free hang like that, okay? Now we'll move over here. This is the nasal cavity, obviously the nares, right? This is the nasal cavity. What is this area? What is this area right here called? The nasopharynx, okay? And then what happens is you will go back through here, right? Into to back the throat, behind the palate, okay? This is the soft palate, the hard palate's up here. You can feel this, right? It's the hard palate's up here. But then it goes into the soft palate. You really can't feel that with your tongue. And then it'll go back into the back part of the nasal pharynx. Now, something to point out, they're pointing out, is your ear does drain into the back of your throat. Why is this important? Well, you've probably heard of otitis media, right? Middle ear infection. Or let me get a better example. Strep throat causing an ear infection, right? The reason is because there's a freaking highway between the two, right there. And if one of those gets clogged up, like if this passageway gets clogged up, you'll almost always get an ear infection, right? That happens a lot in little kids. So just realize there is a connection between your middle ear and the throat, okay? The back of your throat, okay? So there's several places on here that they mention tonsils, right? So here, 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 okay? There's tonsils, okay? And what's a tonsil? See, these are lymph nodes. What do lymph nodes do, right? Lymph nodes are essentially trash cans of the body. They're a collection of white blood cells that sit in a node, right? And they contain lymph, which isn't exclusively white blood cells, but it has a lot of white blood cells. Remember, white blood cells are the ones that go out and fight infection and viruses, and they're little Pac-Man soldiers that'll go to war for us to protect us. And so these are collections of white blood cells that sit within a nodule or node, right? The lymph node. And so these become important occasionally in pathology. Okay, the reason that I'll point these out now is that sometimes you can end up with airway issues when these get really swollen. I'll show you what this looks like. I actually saw a patient today who has Epstein-Barr virus, which is monovirus, right? That's the kissing disease, right? Where teenagers kiss other teenagers and their throat gets really swollen. They get this really pretty gnarly viral infection called mono. It's the Epstein-Barr virus. And what happens is the tonsils can become so inflamed, you have to start worrying about airway. And in fact, on this lady, we've seen her for several days. It is a concern. It was a concern when she first came in. The tonsils were so swollen, which you normally can't see them like that. They were touching. Okay, and they're all filled with pus and bacteria or really virus. It's a response to the virus. I won't get into that, but I'm just letting you know that these can become an airway issue. Okay, they can get so swollen they can touch and close off the airway. That's an extreme case, but in EMS we deal with extremes. Okay, so I'm just letting you know. Now, so that's the tonsils. Okay, now we could just dive through here in the mouth. So air would come in, right? This is the tongue. This you could appreciate how big the tongue really is. It is really really big. What's the thing that connects the tongue to the floor of the mouth, right? It's the lingual frenulum. Okay. And let's see what else. So it goes back, and air will come back through here, through the nose and the mouth, and it meets back here in the oral pharynx, right? Back here, okay? And so what happens is, this is the epiglottis, okay? And remember, the epiglottis is the little flappy flap that will cover the trachea when we swallow. So we don't end up with Dr. Pepper or whatever going down into our trachea, our windpipe that sits up front. So that's the idea of the epiglottis, okay? This picture showing you the same thing, and I think it's kind of confusing for y'all, so I won't go much into that. Now, again, I just talked about all this, but I'll just real quickly reiterate these, okay? So the nasopharynx, formed by a union of facial bones. We'll talk about facial injuries, and you'll learn the facial bones later on in the facial trauma chapter, where we talk about like what happens if you get punched in the zygomatic process and break your maxilla or your mandible or whatever you break, okay, or your orbit. Right? The facial bones aren't very complicated to learn. There's only a few. But so just realize, it's joining of separate bones that create our facial structure, right? So there is a septum. So we have a nasal septum, right? So that's this thing right here in between the two nares, right? It's a piece of cartilage, okay? It tends to get broken when you get smacked in the nose. So that's worth knowing. It also tends to erode when you do too much cocaine. So you'll see that for people that abuse cocaine for a long period of time. And then also, so this is stupid. Y'all do not need to know this. It's lined with ciliated mucosal membrane. That's histology. You don't need to know that, but there it is. And so again, turbinates. Remember, these are like little. So instead of being smooth like this picture dictates, there's little like almost like ridges and valleys within the nasopharynx or within the nose. Then that's where, as air comes in, it turbinates, like it creates turbulence, and that's it starts like swirling around to get filtered and humidified and warmed. Okay, and then sinuses. So do realize that we have hollow bones within our face, right? All over the place, right? So let me just say this: the majority of facial bones are hollow. Okay, and not just like hollow like a femur, right, which has marrow in it, but they have like air pockets, okay, by design. God designed this, okay? And what happens is sometimes we can end up with infection in that. That's called sinusitis, right? And so just be aware of that, that sinuses are real, right? You've probably had sinus pressure before. That's a buildup of something within the sinus, which should normally be air. But if you end up with mucus or pus or something like that in there, right, it creates infection. It can create infection, and that becomes a problem for patients, and it can be painful, okay? Now, the oropharynx, it's found in the posterior of the oral cavity, right? And so the epiglottis they use this word a lot, leaf-shaped, and it's cartilaginous, okay? And it sits just below at the base of the tongue. You can't feel this. You couldn't bring your tongue back to feel this. But it sits back there, and it sits just above the larynx. What's the larynx? The vocal cords. And so, again, when we swallow, it flaps down and covers the trachea, and then it lifts back up when I'm talking because air has to go in and out, okay? So it's like a little flapper valve, like on a toilet or something. Okay. Now, the larynx, right? So this is the larynx is this whole like structure. Okay. So remember, I didn't say it was like the laryngopharynx is like an area, but the larynx is like this whole kind of structure, more or less. The vocal cords, if we're getting very technical, are a part of the larynx, but you really, don't need to know the difference between those two. Okay. Now, something that I've seen them talk about before is the hyoid bone, okay? This is a bone that you might be able to feel up in here. I don't want y'all to because you can break this pretty easily. That sits up in your neck, okay? And we use this sometimes in forensic pathology determine if someone has been hung or strangulated or something like that. It breaks when people get strangulated, or especially if they hang themselves. But if someone gets strangulated, it'll typically break. So they'll look at that. But it's the hyoid bone. Okay, for whatever reason they've asked about that. Now, what they'll do is the main. Oh, so okay, let me see. The larynx is formed of many independent cartilaginous structures. What is cartilage, right? You can feel this, right? It's a little bit more squishy than bone, but it is rigid, right? So it's not solid like bone to where it won't give, but it's a little bit more squishy. It's almost more like a plastic, like compared to being like if bone's metal or wood, right? I would say cartilage is more plastic, rubber like, okay, or a softer plastic, okay. Now, the main laryngeal structure is the thyroid cartilage. So that's this, okay? And you can feel this. Well, you can feel your thyroid, but the thyroid sits right on top of this. So if you ever wonder where a patient's thyroid is, it's right here, okay? And so don't go squeezing on that crazy hard. It's not necessary. But uh, just realize that the thyroid sits here. This is a big part of our endocrine system, right? It sets the basal metabolic rate of the body, so it determines how hot or how fast or hot the body's going to run at in its metabolism, its chemical reactions. Okay, and then of course the parathyroid's there as well. But just realize that. What are those? Right? This is the cricothyroid membrane. So the cricothyroid membrane is just that, right? It's a membrane that's very thin. It's almost like 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 a piece of plastic like this that sits right here, and you can feel this. Right there is mine. You can feel this on yourself. Don't push really hard on this stuff, guys. But you can feel this. And so the reason that I'm telling you this is in EMS as a paramedic, not as an EMT, we will actually take a scalpel, we'll find the structure, take a scalpel, and shove a tube through that if there is a blockage from here up, right? So if someone has a grape stuck in their throat, if that's happened before, right? You might have to make a cut right here and shove a tube down here, because down here is the lungs. Okay, that's the lungs. So basically, if there's a blockage of the highway up here, you have to make the cut here and then go down. Okay. So it's worth knowing that, okay? That's the cricothyroid membrane. It's probably the more vulnerable, actually, I'll just tell you, it is the more vulnerable part of the trachea. You can cut through this pretty easily. You could shove a pin through this, right? So I could take my Apple Pencil and with not a crazy amount of force, push my way into that, if I know where it's at. So the glottic opening is the narrowest portion of the adult trachea. This is important. Notice they use the word adult, okay? But, the glottic opening is the vocal cords, okay? So I meant to put a picture of the vocal cords on here, but the vocal cords have, they move when we talk, right? So if this is the vocal cords, they're constantly moving as I'm talking right now. And so when they're open, right, this is going to be the narrowest opening of the adult trachea. It's something they'll ask occasionally. Now, so that's the upper airway. Again, from here up, upper airway. From here, from here down, lower airway, okay? Oh, this structure right here, this prominence, that's called the Adam's apple. It's called the laryngeal prominence. Let's tell you all that. Women have this as well, by the way, it's just not as pronounced. It's more, testosterone causes this to be more pronounced in men. Now, the function of the lower airway is to exchange oxygen and carbon dioxide. We've talked about this, we're going to talk more about it. And so this is weird, but I could see it popping up. The external boundaries of the lower airway are the fourth cervical vertebrae and the xiphoid process. What? What is that? So basically, the fourth vertebral, it's probably like right here on you. Okay, it's probably like right about here. So from here, which is the fourth vertebra, cervical vertebra, down to, let me just move my camera down. What am I doing? Here, this is your xiphoid process right here. You can feel this. And this gets broken off a lot in CPR. But it's this xiphoid process. So what are they saying? The lower airway runs from here to here. Okay. Worth knowing. So the trachea is the windpipe. It's a conduit, right? It's like I said, it's a fairly rigid pipe that allows air in, and it divides at the level of my dog's name, Karina. Okay. So I've showed you something like this before. No surprise here. I will point this out. Know this order, okay? It goes trachea to the carina to the main bronchi, right? To the smaller bronchi to the bronchioles. So the bronchioles, right, is the smallest. Well, for now, it's the smallest level. Let's just say that, okay? So each bronchus divides until into smaller bronchi, and then the bronchioles. I just said this, and the bronchioles branch into the alveolar ducts. See, that's what I'm saying. It's really not the smallest level until it gets smaller into the alveolar ducts. So this is kind of like, when you grab a bunch of grapes and there's like a little stem, right? The alveolar is the same way. They're on a little stem, and that's the alveolar duct. And then you go into the grapes, and it delivers all the oxygen. Okay. And so the alveoli are the area where it's the functional unit of the lungs where gas exchange takes place. Okay, where does gas exchange take place? Does it take place in the bronchus? No. Does it take place in the mouth? No. Does gas exchange take place in the trachea, carina, bronchioles, bronchi, bronchus, mouth, nasopharynx, oropharynx, larynx? No, it does not. Where does gas exchange take place? At the alveoli. Where does gas exchange take place? At the alveoli. Okay, it's the functional unit of the lung. Okay, so that's very, very important to know because the reason is they have a special word for this. It's called dead space. Okay, so basically, all the way from my nose down to my little bitty alveoli, gas exchange is not taking place. So that air is not really being used to help me, right? It's part of the cycle. We need it, but it's not being used to pick up CO2 and drop off pick up CO2 and drop off oxygen, right? So it's important to know the functional unit of the lung where gas exchange takes place is at the level of the alveoli. Very, very important. Okay. So oxygen diffuses through lining of the alveoli into the pulmonary capillaries. Very good. Yeah. We've talked about this. What's the diffusion? It's simple diffusion, right? Surfactant lines the alveoli. So what's surfactant, right? We hear about this a lot. I talked about this in chapter 17. And what it does is it decreases surface tension to create or to prevent the alveoli from collapsing on itself. So what's surface tension, right? Well, this is complicated, but I'll lay it out for you. The alveoli have elasticity, and they want to collapse on themselves. So by design, the alveoli are very elastic, like a balloon, like a clown balloon. Okay, and because they have elastic in them, and so just like a clown's balloon, it wants to collapse on itself when it gets blown up. Right? The alveoli are the same. When they blow up, they want to go back to the regular size and collapse on themselves. Well, if you have a basket like a balloon, and inside that balloon, the surface area of the inside of that balloon is where gas exchange takes place. Of course, the bigger that area, generally, the more gas exchange can take place because it's a larger surface area. Okay, and so what happens is our body creates this thing called surfactant, and what surfactant does is it's almost like a motor oil type substance, mucousy almost substance that will create the alveoli or it will keep them open. Okay, so it'll decrease the surface tension to where it tells the alveoli just stay open a little bit, right? Don't fully collapse, like don't fully let this balloon fall down on itself. And so that's the idea of surfactant. And where does this become important? Well, it becomes important really in newborns, right? Especially premature children, because you don't really develop this until after week 28 of gestation. A normal pregnancy is around 40 weeks. So premature babies really struggle with this because they don't have enough surfactant. And so what happens is their little grape-like clusters of alveoli fall down, like they just fall down on themselves. And we have a special word for that. It's a fancy word that you actually need to know. It's called atelectasis, right? We'll talk about it later. But, it's right here. It's called atelectasis. How do you say that word? It's atelectasis, atelectasis, atelectasis. Say it with me. Atelectasis, right? It's collapse of the alveoli. So this is when these grape-like clusters collapse on themselves. And so think about this, right? If you have a bunch of smashed grapes in your lungs, right, are you going to get air in and out through those smashed grapes into the capillary beds to pick up CO2 and drop off oxygen, right, through diffusion, right? You're not, right? It doesn't work very well. And so that's the consequence of atelectasis is you have a decreased gas exchange, and this creates this big problem systemically because all the cells are not dropping off or they're not really successfully allowed to drop off the CO2 at the lung and pick up the oxygen. So you end up with some respiratory issues. So who gets atelectasis? Of course, this, like I said, this happens in newborns if they're not treated, right? This can also happen in people with like infection, especially severe infection. This happens with people after trauma, pancreatitis, infection, trauma, pancreatitis. There's a few others, but those are probably the bigger ones that just immediately come to mind. So you could certainly get atelectasis you could get this from asthma too, but you could certainly get atelectasis from pneumonia. So in fact, it's common. You could get atelectasis from, like I said, pancreatitis, which is a one-off. You could get this from trauma, right? So if someone takes a baseball bat and breaks 5 of your ribs, that section of the lung isn't going to be breathing very much. It's a long story. So it'll kind of like almost a little bit collapse on itself. It won't be as ventilated because it hurts. And so you can end up with atelectasis, okay? There's a lot of different ways we can get atelectasis actually, but just know that this is when alveoli, these little grape-like clusters, collapse. So instead of being a nice round grape, they just fall down on themselves. Whoops. So the lower airway, this is again between the lungs, right, is this area called the mediastinum. That's this word right here, mediastinum. Okay, mediastinum, and it's basically this like I don't want to use the word pocket, but it's an area. So in within the mediastinum lays the heart, the aorta, the thymus if you're a child, and a few other structures, right? But it's an area to know, right? There's not a lot of areas, but I mean, there's not a lot of stuff that we do with this in EMS, but it becomes important a little bit with like more advanced pathology. Okay, so just know the mediastinum sits right here. It's in the middle, media, right? If you don't know, media means like half or middle in Spanish. Okay, mediastinum. Okay, and then the phrenic nerve innervates the diaphragmatic muscles, allowing it to contract. That sounds like a freaking test question, right? So the phrenic nerve, which I'll just have you know is cranial. Actually, no, it's not. I'm not gonna say that. The phrenic nerve. This isn't a good point. The phrenic nerve runs off C234, right? Wait, C234. Keep the diaphragm alive. No, it's 456. Keep the diaphragm alive. I say stuff out loud. I say shit out loud with y'all, then I question myself. Anyways, it runs off a cervical portion of the neck. It says in your book, look it up. And what happens is it runs down through your neck, okay, like down like through here, through your shoulder, okay, and then it'll go down into the diaphragm. What's the diaphragm? Remember, this is like a fairly smooth, or it's not smooth, but fairly thin muscle that sits right up underneath your ribs, okay, and so it will when we breathe in, you should know this process by now. When we breathe in, muscles contract. Okay, so when muscles get smaller, just like when I contract my bicep, it gets smaller. When this muscle contracts, it gets smaller, and so when it goes like this, it pulls downward. And when it pulls downward, it sucks air in because it creates a greater negative pressure than the atmosphere, and so it sucks air in through the mouth, trachea, into the bronchioles, right, into the alveoli, right. And so that's the process of this. So what stimulates this muscle to work? Right? It's the phrenic nerve. Okay, and so the phrenic nerve controls the main muscle of breathing, which is the diaphragm. So there's two test questions I'll throw your way. Excuse me. What is the main muscle of respiration or ventilation? Right? It's going to be the diaphragm. Question number two. What is the main nerve that innervates the main muscle of breathing? It's the phrenic nerve, which innervates the diaphragm. Okay. And so those are questions to know. And why was I telling you about this thing running through your neck and stuff? Well, just kind of lay a foundation now. Over here, this patient's right? This lays the liver. And within the liver, we have this gallbladder, okay? And sometimes this gallbladder can get so irritated and inflamed, you can end up with pain up through the neck and in the shoulder. It's called referred pain because this area will get inflamed and the body's like, I'm not really sure what's going on here. And so instead of feeling pain down here, sometimes we can also feel it up in our neck. What happens more commonly, and probably a better example for you, is the spleen. So if the spleen gets hit with a baseball bat and it starts bleeding, it'll bleed onto the diaphragm, and the diaphragm will get really irritated. It's like, yo, why is there blood all over me? And so instead of feeling pain down here, we'll feel pain up here in your left shoulder. Okay, it's the patient's left. And so basically that's called referred pain. Okay, that's just an example of referred pain. So I'm just letting you know when the diaphragm gets pissed off, a lot of times you'll feel it up in the neck, okay, or in the shoulder. You'll feel it because that's where the diaphragm runs, or the phrenic nerve runs. Okay. So here's a question: if the phrenic nerve gets cut, guess what happens? You die or you quit breathing, and then you're probably going to die. So that's the importance of the phrenic nerve, and that's why they want you to know that. This is also why cervical trauma becomes relevant because if someone breaks C3, right, there's third cervical C1, 2, 3, 4, right? If they break one of those, right, you pretty much just die because your phrenic nerve gets cut, right, or damaged, and it won't, then you quit breathing and you die unless someone's right there to fix it and breathe for you. Plus, you'd lose you'd probably die. But anyways, So the physiology of breathing. So what's physiology? It's how things work within the body. Okay. And so the respiratory and cardiovascular system work together. Like they're good pals, right? They're like good friends. Uh, never go through a divorce. Like they're good guys, good friends. And so basically, uh, obviously they ensure that every cell in the body has to get a constant supply of blood, and within that blood is oxygen and really glucose too, to do their job. Okay, and nutrients, right? There's other. I need y'all to know that I use the word oxygen and glucose, but there's a few. I mean, there's other things you need, obviously, but those are the main ones, right? Without those, we die really quickly. And they ensure that carbon dioxide and waste products, carbon dioxide is probably the biggest one, are removed from every cell in the body, right? So that they work together. Okay, so basically this clock becomes kind of important and it's testable. Okay, so they're just talking about the heart muscle, and I need you to know that my bicep loves oxygen, right? But it doesn't require it as much as my heart does, or my brain, or my kidneys, right? To where I could go probably 2 3 hours without oxygen in my bicep and it would be pissed off, but it wouldn't die, right? But the heart's different. Okay, so within 0 to 1 minute of no oxygen, right, or no ventilation, right, going. So let's just say, so I'm choking, right? There's a big old chunk of deviled egg in my throat. No air is going in and out. Okay, or mozzarella stick. Almost died on a mozzarella stick once. And so, within the first 0 to 60 seconds, right, first minute, your heart's gonna become irritated. Okay, and it's gonna start like beating a little bit odd, but that's not important. And it's gonna be really irritated. Okay, and so you're probably gonna start getting some chest pain, right? You're obviously gonna be very anxious, right? And it's just talking about the heart. And then from 0 to 4 minutes, the brain damage, not likely, right? So someone can hold their breath for about up to 4 minutes, and their brain, for the most part, it's not going to have noticeable difference. There are probably going to be some damage, but it's not going to be like very noticeable difference, okay? But from the 4 to 6 minute mark, brain damage is possible, okay? Oh, that's fine, okay. And you've probably seen this. Like, I remember doing crazy stuff when I was a kid and holding my breath for like 2 3 minutes underwater with my brothers to see how who could win. But I'm just saying, 4 to 6 minutes about the limit. That's when the brain really is going to start dying, or start getting damaged. And then 6 to minute or the 6 to 10 minute mark, brain damage is very likely, right? And then more than 10 minutes, it's irreversible. So something to know about the heart and the brain, and the reason they use these examples is they're very oxygen dependent. And when they don't get their oxygen, the cells will explode. They lyse, okay? And when they lyse, they don't come back, right? So when the brain dies, as an adult, when the brain dies or a heart cell dies, it will never come back, right? They don't regenerate. And that's an important phenomenon because that's the phenomenon of heart failure and stroke, right? We don't get better after heart attacks generally, right? Like once that section of your heart dies, it just stays there as like a scar tissue. Same thing in the brain, right? Like when that portion of the brain dies, it's just dead. It doesn't like come back to life after a period of time. Like perhaps, your skin, right? You could scrape your skin and kill it or burn it severely and have that area die. And it'll usually come back in some factor. But the brain does not, neither does the heart. Those are the two structures. So why am I telling you this? Because these structures, we tend to really focus on an EMS. Okay, so with that, every structure depends. Every cell, right, needs oxygen and glucose, right? But what we tend to really see a big focus on is the heart and the brain because they're so dependent on oxygen. When they don't get it, we see really appreciable effects of that. Okay. So again, ventilation is a mechanical process. It's moving air in and out. Inhalation is an active process, right? So this is active, right? It's the muscular part of breathing. I have to think to breathe, right? If I'm dead, I don't breathe in, okay? Inhale, right? I don't. That's an active thing. You can't do that as a dead person. And so air enters right through the mouth and nose down into the trachea. And so the diaphragm will contract. Remember, when muscles contract, they get smaller. So it contracts and it pulls air in, creates a negative pressure greater than the environment, and it pulls air in, and the lungs will fill with air. Okay, that's how that works. What's intercostal muscles? I should talk about this. So intercostals that meet between your ribs, those are actual muscles, and we can use those to help us breathe. And they're the secondary. Well, I wouldn't say secondary. The main muscle of ventilation is the diaphragm, and then the intercostals are close seconds. Now, this is what they're showing you here. Again, just imagine if a diaphragm contracts, right? Right, sitting here in my chest, when it contracts, it gets smaller, so it pulls tight, and then it is pulling air in because it is sucking air in because you're like it's almost what they do is you've probably seen this in high school class, right? Is that you can pull air in like this, okay? It's almost like pulling the bottom of a plunger, right? Like you're pulling air in. That's what's happening here. Now, exhalation does not require muscular effort. This happens through elastic chest recoil. So the lungs are elastic, it's just like blowing up a balloon. Very active process. Letting go of the balloon, it does its thing. It doesn't even need the energy stored in it. So it just lets go, right, and it'll collapse on itself and it'll exhale. So just know, basically, the exhalation is a passive process. And the reason I tell you this is because dead people can breathe out. And I've seen this before, like you go to a hospice call or something like that, right? Or a dead person, and then you're telling the family, hey, I'm very sorry for your loss, here are the next steps, blah blah blah, right? You're talking to them, and the patient go, right, and they're dead, like they're legit dead, and the family's like, oh my god, they're alive, right? No, they're not, because what happened is their lungs finally let out that last little bit of air out, and it went through their glottis, through their vocal cords, and it created a noise. I've had this happen several times actually. So just be aware of that. Um, it's not a general practice, but don't do this in the field. But I'm just saying, if you were to take a dead person and push on their chest a little bit like this, just push a little bit, you're gonna feel that air will come out, and sometimes noises can be made through the glottic opening. So just be aware of that. Okay, exhalation is a passive process. Now, the regulation of ventilation is very complicated, but it's manageable. But we got to know this very well, and you got to be able to explain this to me. All right. So we have a bunch of receptors and feedback loops, right? All throughout the body. The main ones that we have, though, are in our brainstem, specifically the medulla, okay, or the medulla. Really, it's the medulla. And so, if you ever watch Waterboy, right, they talk about the medulla oblongata, right? It's what I'm talking about. It's in the brainstem, so it sits back here at the top of the spinal cord. So it's like right about here. And so, what happens is the pH, so the acidity or the basicness of really it's acidity of the blood and within the CS, cerebral spinal fluid, right? So there's fluid that floats around through that coats our brain. Um, that has a pH, okay? And the normal pH of the body, I told y'all this a lot, is, tell me, 7.35 to 7.45. And so what happens is as CO2 builds up within the blood, right? Remember, CO2 is acidic. It starts moving the normal pH of 7.4. If it builds up this way, right, it becomes more acidic. Okay, and as it becomes more acidic, okay, it enters the blood. The blood and the cerebral spinal fluid become more acidic. It touches on the medulla, and there's a receptor back there and a feedback loop. And so, yeah, and so basically, what happens is that is what stimulates us to breathe. So, test question. What stimulates us to breathe? It's not low oxygen levels. It is high CO2 levels that stimulate us to breathe normally. Okay? Say that again. What stimulates you and I watching this video to breathe? It is high carbon dioxide levels. Where at? The medulla in the brainstem. It is not low oxygen levels. Okay? So, when oxygen levels rise, respiration and total carbon dioxide levels stimulate. Yeah. That's a complicated sentence that I really wish I probably would have deleted for y'all. So disregard this for now. We'll talk about this in chapter 17. Now, oxygenation, right, is the process of loading oxygen molecules onto hemoglobin, which is part of our red blood cells, onto hemoglobin molecules in the bloodstream. Okay? And adequate oxygenation is required for internal respiration to take place. So what does this look like? There's a picture coming up. Let me just, I'll come to this picture, but hang with me on this, okay? So I'll just draw it for you, actually. This is a red blood cell. They really do kind of look like a donut. And so within this red blood cell is a particular molecule called hemoglobin. And it's a combination of heme and globin, right? And there's iron in here that gives it its color. And this is our red blood cells, right? And when they're loaded with oxygen, they're red, and when they're not, they're more of a purplish color, right? Oxygen creates this color change of the iron. And so what happens is this holds oxygen typically, or always actually. And so this process of oxygen hopping onto hemoglobin, which is a part of our red blood cells, that's called oxygenation. Now, metabolism, that we've talked about this in physiology, right? This is when cells take energy from nutrients through a series of chemical processes. So when you hear the word metabolism, I want you to think like a chemical reaction, okay? Each cell combines nutrients and oxygen to produce energy and waste products. What it process that called, right? Cellular respiration and the electron transport chain create ATP, right? That give the cell the energy to do its job. Okay, ATP is the currency of energy in the body. Okay, now the process of exchanging oxygen and carbon dioxide occurs through diffusion. Talked about this a lot. What is diffusion? This is the nasty guy that rips a fart right next to you in the classroom, and it's a really in a higher concentration near his butt, and it moves its way towards your little nose, right? So that is going from an area of high concentration, the gas that he farted, went from an area of high concentration near his butt to your nose, to an area of lower concentration, and you ended up smelling it. That is diffusion, okay? Now, uh, they're being repetitive, so it's annoying. But this is what I want to show you. Within the alveoli, there is, remember, these are almost like little grapes, right? And this is microscopic. You cannot see this with your naked eyes. Um, Oxygen will move into the capillary because there's a higher area or percentage of oxygen within the lungs, it's around 21%, right? Moving into the capillary beds because there's a lower concentration in the capillary beds, okay? And CO2 is in a high concentration within the capillary beds and will move into the alveolus because there's like less than 1% of carbon dioxide in the atmospheric oxygen. There, we're breathing in and out. Very, very little carbon dioxide in it. Okay? And so that is the process of diffusion. High concentration to low concentration. Just so happens there has to be a higher concentration within the alveoli and a higher concentration of CO2 within the capillaries. Okay? So that is the process of gas exchange. And where does gas exchange take place? In the alveoli. By the way, alveolus is a single alveoli. That's what they're talking about that. So the exchange of oxygen and carbon dioxide between the circulatory system and body and the cells of the body is called internal respiration. Okay, let me just point this out. External respiration means external with the environment. Okay, like the air we're breathing in. Internal respiration is at like the actual cellular level, like down at your big toe and up at your brain. Okay, so this is at the tissue level. Okay, the other cells outside of the lungs. Right, this is where internal respiration takes place. Again, here's how this happens. There's oxygen loaded onto these red blood cells bound to hemoglobin. Okay, and what it does is it will look at the cell and through diffusion, right, high concentration, low concentration, just like a fart, it'll load off from this hemoglobin into the red blood cell or into these cells. I'm sorry, the tissue, right? So this could be my big toe, and then that is the process of gas exchange. Okay, but the cell through the electron transport chain, cellular respiration, right, glycolysis, created CO2. So CO2 is built up in the cell. Remember, CO2 is acidic. So the cell's like, I need to get rid of this stuff. I don't want it. So it'll drop it off at the capillary membranes to the blood. Now, here's where it gets annoying, and I hate to tell you this. CO2 is actually not bound to hemoglobin typically. It's actually bound in the plasma. What's the plasma? That's like the yellow straw-colored stuff within your blood. You've probably seen this in wound healing where you'll see like some clear fluid around a wound, right? That is plasma that's leaked, right? And so that's CO2 is actually bound in the plasma. It's not bound to hemoglobin, which gets a little pedantic, but you really, I mean, I don't want to get too crazy into that. Just know, again, it's diffusion, high concentration to low concentration. There, and what's annoying about this too, CO2 is the one that's a pain in the ass because it changes the rules. Is CO2 requires something called carbonic anhydrase. It's an enzyme that all our body, everyone has. You wouldn't live without it. That facilitates that process. And again, that gets really complicated, and it's a whole nother discussion. But just know, high concentration, low concentration at the cellular level, right? With cellular tissue, I should say, is internal respiration. Okay. Now, what is aerobic metabolism? So aerobic metabolism occurs in the presence of oxygen. Okay. So if you've ever heard of someone doing water aerobics, right, or something like that, right, it requires a lot of. I just like to think that requires a lot of oxygen to dance in water like that. So that's how I think of aerobic metabolism. Even to this day, I still think of that. And so energy right, is created. So we drop off energy at the cell, and it makes its way to the electron transport chain within the mitochondria, and through the Krebs cycle and oxidative phosphorylation, right, which is the fancy word at the electron transport chain, we create ATP, right, adenosine triphosphate. And then ATP goes through the cell and does all these things like muscle contraction or whatever, uh, fires on neurons, right? ATP is almost like the dollar bills of the body. So it's like a currency of energy, to where you have to pay to play, right? So that's what's happening with ATP. When ATP gets used up, it becomes ADP, adenosine diphosphate. Okay, AD with it like a D as in dog, diphosphate. Okay. Now the second process is called anaerobic metabolism. So ana means without actually, and so without aerobic, excuse me, without oxygen, that's what they're talking about. So what are scenarios when we wouldn't get enough oxygen, right? The lungs are not working, the heart's not working, they're not working fast enough to keep up with the demand of the cell, right? So we can switch to anaerobic metabolism. So we've actually experienced this if you ever go to the gym and start lifting weights really fast or running really fast, right? The cells can switch, especially muscle cells, to anaerobic metabolism really quickly and and remember, anaerobic metabolism is creating energy without oxygen present, and it's not a very efficient process, right? You lose. It's just like instead of 32 ATP, you'll get like 2 net. So it's not very efficient, but it's still, we still use this. So, your body relies on this. Example is you've seen this at the gym to where like, a few days later your bodies are sore because it creates this thing called lactic acid, right? So it builds up on the muscles and it feels unpleasant when it sits on them. So that's how we get sore muscles after the gym. And so just be aware, we've covered this, right? Anaerobic metabolism is without oxygen. Okay. Now again, so neural means like brain, neural control for breathing, right? The primary control center is the medulla. And they're going to say the pons too, but really I want you to know medulla. You could know the pons as well. That's fine. But the medullary respiratory centers control the rate. So how fast we breathe. Are we going to breathe 12 times a minute or 16 times a minute or 20 times a minute or 40 times a minute? The depth, are we going to take normal breaths in or really deep exaggerated breaths in because we just finished running? And the rhythm. So we can see these things, these pathologies called like chain Stokes or apneustic or biot's respiration. We're going to talk about what are these, right? These are patterns, okay? And the apneustic center of the pons is the secondary control center, sure. And so I'll just draw this for you. This is going to be a really bad drawing, so hang with me, right? If this is someone's brain, right, we have the midbrain, uh, and then we have the pons, the medulla, and then this is like the spinal cord, right? So I'll just, whoops, right? So this is the midbrain, this is the pons, sticks out like that, and this is the medulla, the foramen magnum, and this is the spinal cord. Now, again, these are, and then all this sits within the skull. So just be aware of that, okay? Back here would be the cerebellum. Now, just be aware of that, okay? So the pneumotaxic center has inhibitory influence on respiration. Now, yeah, it does. Also, we have baroreceptors within our lungs too that will prevent overstretching, so you can't take too deep of a breath in and blow a lung. It's also like stimulates coughing and stuff like that, kinda. So chemoreceptors. What does the word chemo mean to you, right? It means like chemical, right? When I think oxygen, like the periodic table of elements, CO2, I think chemicals, okay? So you should think of it that way, right? Oxygen is a chemical. Well, it's really an element, but chemo, right? Chemoreceptors, right? So these are sampling blood again, right? Or they're sampling the pH of the blood, okay? And obviously constantly, as long as you're alive, monitoring the chemical composition of the blood fluids. So they're just constantly just tasting the blood and saying, oh wow, it's too acidic, it's too much CO2, it's too much oxygen, blah 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 blah, right? So that's what they're doing. Now we have chemoreceptors, right, in the aortic arch that measure the amount of carbon dioxide in the arterial blood. And here's where so the aortic arch would be like, I'll just point to myself, it's right here, okay? You actually feel it. If you push down right here, yeah, you can feel the top of the aorta, and it's right about there where that sits. And so it's sampling the blood, okay? We also have the central chemoreceptors, and these monitor the pH of the CSF. Okay, so the chemoreceptors in the carotid body, if they're getting a little pedantic, those do measure arterial blood. They measure CO2, right, carbon dioxide. And then the central chemoreceptors in the brainstem, those measure pH of the CSF, the cerebral spinal fluid. Okay, this is the fluid that coats the brain, and it changes. If the pH of the blood rises, the pH of the cerebral spinal fluid will also increase. The dorsal respiratory group you don't need to know that, is responsible for initiating inspiration. You don't need to know this. The ventral respiratory group is responsible for motor control and inspiration of expiratory muscles. I don't want y'all to memorize that. That's fine. Now, the pathophysiology of respiration, uh, this is obvious, right? But if any part of this gets messed up, right? The chemical part of it, the ventilation, the oxygen side, right? A mechanical force, whatever gets messed up. Obviously, there's pretty immediate effects, and you could see this, right? If I started choking you with my hand, right, you would have pretty immediate effects throughout your body because of this. Okay. Now, there's a few words that sound pedantic, but you really do need to know them. Hypoxia, hypo means low, right? Just like hypothermia or hypotension, right? Hypoglycemia. Oxia. So hypoxia means low oxygen to the tissues, right? In the cells. Now, yeah, that's fine. I hate that. Hypoxic drive stimulates breathing when the arterial oxygen levels fall. Kinda. Yes, this is a different system that I talk about in chapter 17. I'm going to glance over this for now because I discussed this very, very heavily in chapter 17. But sure, we'll go with that for now. Again, I explain this coming up. Now, when our cells don't get enough oxygen, right? Let's just say I'm breathing 6, 7 times a minute instead of 12, 16 times a minute, right? I'm breathing half as much as I should. You're going to start seeing the patient get restless. So they're going to get real fidgety, right? They're going to be like, I can't breathe, I can't breathe. If you've ever seen someone who can't breathe, they become very irritated and restless. And they'll be like, I can't breathe, right? They get very manic, right? They get very scared, right? They're restless, irritable, they're apprehensive, right? And they can become tachycardic, right? Which is a fast heart rate, and they're going to become anxious. So when you see a patient or you see a vignette of a patient that's tachycardic and anxious and very irritable and they won't sit still, right? You need to be thinking, oh, is this a respiratory issue? Okay, look for that. And then late signs of hypoxia are going to be altered mental status, mental status change, also known as altered mental status. They could have a weak, thready pulse. Remember, a weak, thready pulse is where instead of like a boom, boom, it's just kind of like not as prominent, okay? And cyanosis. Remember cyanosis, the bluest tinge of the skin, okay? And then so we have this thing called a VQ mismatch, okay? This is complicated. I talk about this in chapter 17, but it's called VQ. And so ventilation is obviously V and perfusion is Q. Why they couldn't use P, I don't know. I didn't come up with the rules, okay? But when you hear me say Q, I need you to think perfusion. What is perfusion? Remember, perfusion is the cells getting the proper oxygen or the nutrients they need and dropping off their trash, right? That's cellular perfusion, okay? And so ventilation, as in the air going in and out, and the gas exchange taking place at the cellular level, they have to be matched to exchange gas to exchange gas by simple diffusion, right? So basically, these systems have to match each other, okay? So we could almost, and the reason I'm using a ratio is this will make sense with pulmonary embolism, is let's just say this ratio is like 10 to 10, okay? I'm making up arbitrary numbers here, but 10 to 10, they kind of have to match each other, okay? And so with impaired ventilation, think about this. If I'm breathing, let's just say 6 times a minute instead of 12, right? For a while, blood's still passing over those capillary membranes within the alveoli, but air is not, okay? So I have impaired ventilation because I'm only breathing 6 times a minute, right? Half as much as I should. But that doesn't mean that there's not perfusion taking place at the alveoli. The alveoli they're still being perfused. They're still getting blood. So you might see a ratio like this. Instead of 10 over 10, you might see a 5 over 10. And you don't need to know these numbers. I'm just trying to point something out, okay? So that would equal like 0.5, right? And this happens in bradypnea, right? Someone's not breathing enough. Okay, that's a good example of that. And inadequate perfusion will cause less oxygen absorption in the bloodstream and less carbon dioxide removal. What does this look like? Okay, well, I don't have a picture of it, but let's just say I took a big old blood clot and stuck it in the pulmonary artery. What's the pulmonary artery? It's the big artery that goes out of the right ventricle and delivers all the venous blood, right? Or I shouldn't say all the it's arterial blood, but it's deoxygenated blood to the lungs. And so what happens is if I get a blood clot there, it's called a pulmonary embolism. Again, I talk about this in chapter 17. And so what happens is you will end up with a perfusion mismatch. So imagine you're cutting off the blood supply to the lungs, right? So you end up with a ratio like this. You end up with, remember, ventilation is still good. Air's still coming in and out of the lungs in this scenario. But in this scenario, the perfusion is less, okay? Because there's less blood going to the lungs because there's a blood clot blocking the highway, pulmonary artery, that allows deoxygenated blood to go to lungs to drop off CO2 and pick up oxygen. So, there's a bug. So a fly or like a mosquito. Anyways, so what happens here is this number is 2, right? 10 over 5 is 2. So that's what they call an increased VQ. Okay, and this concept uh, gives students a run for their money because they get real lost on these ratios. And you're not going to be tested on this exam, but you will in the respiratory chapters over VQ mismatch. But this is just a general rule that you need to know. And so the reason I'm telling you this, and they're talking about this, is this ratio, instead of being 10 over 10, again, arbitrary number, could be, these weird numbers. And so they'll ask you, in the case of a pulmonary embolism, is it an increased or decreased VQ ratio? It's an increased VQ ratio. In the case of airway obstruction, right, like a battery stuck in, or a peanut stuck in the right main stem bronchus, is that a increased or decreased VQ ratio? It's a decreased ratio. Okay, so that's how they work. So we'll talk more about this. This is a little bit probably on the highest end of the spectrum of complication for EMT exams, but it can be tested and it is worth knowing. Okay. Now, factors affecting ventilation. Interruptions to the central or peripheral nervous system, right? So again, if I were to cut the phrenic nerve, which is part of the peripheral nervous system, right? Your diaphragm's going to quit working, so it's not going to work. So you're probably going to end up dying, right? You're going to mess up your ventilation. If I, cause a massive stroke to your brain and it no longer works, right, to send the signal to the phrenic nerve, right, which is the central nervous system, down to the peripheral nervous system, you would die. Okay. Now, a word that they're going to use here is hypercapnia. Okay. So hyper means too much. Like if a kid's too hyper, they're too much. You're too much, right? Capnia means carbon dioxide within the blood, actually, specifically. So when you see the word ia, like nia, right? Anemia, right? IA, you need to be thinking blood, like in the blood, right? So hypoxemia, right? That would be like low oxygen within the blood. Hypercapnia, right? That means that there's an increase in carbon dioxide in the blood. Okay, so that's just a vocabulary term. I'm sorry. Now, trauma to the head or spinal cord can cause this. I kind of gave you some examples of that, right? Someone shoots their head off, right? Or takes a knife right to the back of their neck, right? Their respirations will probably stop. Okay, or certainly be affected. Muscular dystrophy, right? So this can happen. Well, there's several ways this can happen, but this isn't just like Duchenne's or Becker's muscular dystrophy, but this can also happen from like severe forms of multiple sclerosis, Guillain-Barré syndrome, true muscular dystrophy, like I said, like Duchenne's or Becker's muscular dystrophy. So there's well, actually, I should go back. Guillain-Barré and multiple sclerosis are not muscular issues; those are nervous system issues. But actual muscular dystrophy, like this is rare. It happens in boys, like Duchenne muscular dystrophy or Becker's muscular dystrophy. This is where the muscles themselves get jacked up, and so they don't work very well, like all the muscles, including the diaphragm. So they can end up with respiratory failure. Well, again, that's still, well, I'll go back to interruptions of the peripheral and central nervous system. Again, this could be trauma, which is obvious, but again, it could be multiple sclerosis, Guillain-Barré syndrome, polio, There's those are probably the big ones. ALS, Lou Gehrig's disease. That's another one that can cause this. Uh, there's a few different ways this can happen. Anyways, moving forward to this last bullet point, angioedema. What's angioedema? Right? This is swelling of the mouth and lips and tongue. Um, and bronchoconstriction from allergic reactions. This can also happen in anaphylactic reactions, which is an extreme allergic reaction. And so basically, the bronchioles can actually constrict. There's smooth muscle in them that will constrict, and they also swell. They'll get like fluid, like edema, and they'll swell. Factors affecting ventilation. So extrinsic factors like trauma or foreign body airway obstruction. So we see foreign body airway obstructions in children. You have to be aware that when children start crawling, they put everything in their mouth, and sometimes they'll end up choking on them. Golly, I dropped my pen. Not my day. My bad. Okay. So children put everything in their mouth. Okay. So of course, trauma like I don't know. I mean, guys, trauma like a clothesline, right? Someone's clotheslined or hangs themselves or something like that, right? That would certainly affect the ventilation. Hypoventilation. Remember, hypo means low, and hyperventilation means fast. You gotta know those hyper terms. They show up all the time. If you know those, you can usually stumble your way through a problem. And we talk about that in medical terminology. Okay. I'm actually going to end the video here because we've been talking a while, and we will pick up the factors affecting oxygenation and respiration in the next one. So thank you for your time.